It is my pleasure to introduce our notable keynote speaker for today. She is a maternal fetal health expert, Dr. Ann Borders. A little bit about Dr. Borders. Dr. Borders is a maternal fetal medicine physician with North Shore University Health System Department of Obstetrics and Gynecology, and is a clinical associate professor of obstetrics and gynecology at the University of Chicago, Pritzker's School of Medicine. She is the executive director and obstetric lead for the Illinois Perinatal Quality Collaborative. She is a member of the Illinois Maternal Mortality Review Committee and serves on the National Network of Perinatal Quality Collaboratives Executive Committee. She is also on the National Institute of Health funded researcher focused on addressing disparities in pregnancy outcomes of vulnerable populations. Please be sure to read the full description of Dr. Borders' bio in today's program. Dr. Borders' presentation is titled The Illinois Perinatal Quality Collaborative, Improving Care Together. Dr. Borders, thank you and welcome.
Thank you, Patricia. I'm so appreciative of being here with all of you. Can everyone hear me okay this morning?
Yes, we can hear you.
Great. I am really honored to be sharing with you this morning on this amazing two-day meeting that you're having. I also was really moved by Dalton's words this morning. I found them really beautiful and moving, and I'm sure I speak for everyone and just thanking Dalton for really reminding us why we're here and grounding us in his message, which I felt came directly from his grandfather, which really just gave that this is where we're here to do important work, and we're here to take care of generations. And I think that's the message that we're going to resonate today. This work is important and it's necessary because we're caring for families. And I think Dalton really got us in the right mindset to be thinking about this work. I feel very honored to be sharing the work that we have done in Illinois. I'm definitely part of a group of many who've been doing this work in Illinois. I speak for the patients of Illinois, our patient partners who help us with this work, our community partners who help us with this work, doctors and nurses from across Illinois who've come together to try to improve care and outcomes for pregnant women. So I'm hoping to share today what we have been working on and inspire all of you if there's lessons learned from our work that you can take forward. I have no conflicts to report, and I appreciate the funders who've funded this work for the Illinois Perinatal Quality Collaborative. I'm going to be talking about the urgent need to address the maternal mortality crisis. I don't, I think, need to speak long about this. That's why we're all here. That's why you've got on this call today and devoted 2 days of your busy lives to really think together about how we can address the maternal mortality crisis across the country, in Arizona, and in your own corner, wherever you're working in the space that you're in. I want to share the role of Perinatal Quality Collaboratives and ILPQC's approach and think about work that may, and I know you're going to be talking about some AIM initiatives later today, and I think that hopefully will resonate with some of the work that you're trying to do in Arizona. I'm going to briefly talk about the Mothers and Newborns Affected by Opioids Initiative and the Birth Equity Initiative, so give some examples, and also I'll touch base on the Promoting Vaginal Birth. So clearly there's an urgent need for strategies to address the maternal mortality crisis. I think many of you have seen those images, but the reason we're all here today is that things are not getting better in the United States. We do have a maternal mortality crisis. I think we have the country's attention. I think people are paying attention to this crisis, but it's up to all of us to come together to figure out how to solve it. It's not just that maternal mortality is rising, but the fact that these dire disparities exist for American Indian, Alaska Native, and Black women who have 2 to 3 times the rate of maternal mortality. And this is an unacceptable crisis that takes all of us thinking about this and working on it as a priority. Certainly, it is a priority in Illinois. This is what our data looks like in Illinois in terms of our pregnancy-associated mortality ratio, with a significant higher, about 3 times the rate for non-Hispanic Black patients compared to all women. I think when we're thinking about data, I always like to take a moment to think about, these data lead to headlines, but really what we're talking about are women and their families. These birthing people who lost their lives during pregnancy or the postpartum period. Each of them is a person loved with multiple ripple effects in their family and their community from their death. And so I really want to ground this work in that these maternal deaths could be your mother, your sister, your daughter, your partner, and it demands our attention. I think as we think about how to do this work, one of the things I like to ground ourselves in is thinking about where the maternal mortality crisis, where it arises, where the disparities arise, and helps us just base our work and really understand where we're coming at our ability to bring solutions that can make a difference. And I think that when we think about root causes, I'm not going to spend time focusing on this issue, but I think it's important for us to think about how structural and systemic racism leads to impacts that impact our communities, that leads to disparities in maternal mortality. And I think that the areas that we are going to be able to address and that we're going to be thinking about today is how do we improve quality of care. But if we don't think about quality of care and how it sets in the way that it can lead to disparities in outcomes, then I don't think we're really digging deep enough. So I think it's important that we understand how unconscious bias, how discrimination leads to differences in care, and how our resources and our social determinants of health that our patients come to us in clinical care with, how those impact pregnancy outcomes. And so all issues we need to be thinking about as we address this work. In terms of quality of care and how it contributes to disparities, in 2003, the Institute of Medicine published Unequal Treatment, which talks about how racial ethnic disparities in care of patients really contributed to lower quality care, that provider stereotyping and bias contribute to disparities. So this is not a new topic. This was first published by the Institute of Medicine in 2003. So this has been 20 years of us thinking and talking about this topic. And so I think that it's important to know that this is an area that people have been thinking about for a long time, but I do believe that that now is the time that we are seeing folks ready to really address these issues in ways that can make impact on a larger scale. There is evidence that quality of care is an underlying cause of maternal disparities, and that quality of OB care varies across delivery hospitals, and that sites of care receiving increasing attention as a mechanism for disparities in maternal and infant health. Improving care in hospital are a critical lever to improve maternal outcomes. If any of you have read Elizabeth Howell's work out of New York, I really encourage you to don't have time to go into her articles today, but the reference is here, and I encourage you to review her work. And certainly her data would show that that this difference in care really matters. We know that more than half of maternal mortality and severe events are preventable. And her data has demonstrated that both within hospital and between hospital disparities exist for severe maternal morbidity, and that quality of care received by patients during childbirth may differ by race and ethnicity within individual hospitals. I think the reason I'm talking about this is to really point to why it matters that we focus on quality of care. How do we standardize quality of care across hospitals and within hospitals? And that kind of work is the kind of work that perinatal quality collaboratives do, and that these kind of large state level initiatives can do. It's really about standardizing care and really thinking about quality of care across all hospitals and for all patients. So that really brings us to talking about how perinatal quality collaboratives can function in this space of improving quality. and I'm going to share the example of ILPQC. So when we think about reducing maternal mortality and morbidity at the population level, there are three kind of branches that I've spent a lot of time thinking about at the national, at the state level, and that would be maternal mortality review committees to really conduct those detailed reviews of why maternal deaths happen and what we can do to prevent them. Perinatal quality collaboratives who can take those recommendations from MMRCs and try to put them into action. So what are the leading causes of death in your state? What is preventable? What can we do better? And then PQCs and other groups that lead statewide initiatives can then take those recommendations and make a difference. And then we have AIM that creates bundles and resources which we can utilize, those safety bundles, to really implement this work and make change happen. So this is the status of PQCs in the United States. We have PQCs now in almost every state. The green are the states. There's 27 states now with PQC state CDC funding, but certainly this is a growing movement across the country to have perinatal quality collaboratives in every state, and they really have them partner with their maternal mortality review committees and partner with AIM. So this is ILPQC. We are a statewide network of perinatal clinicians, nurses, hospitals, patients, community stakeholders, and public health leaders. And we really work together to implement data-driven, evidence-based practices to equitably improve outcomes and reduce disparities for both mothers and babies across Illinois. So we touch over 99% of Illinois births. We work with over 100 Illinois hospitals across our state, and that's urban hospitals, big hospitals, safety net hospitals, small rural hospitals. We really have a very wide variety of hospitals across the state of Illinois that we work with, both urban and rural, for sure. This is what our infrastructure looks like. The ILPQC Central sits in the middle. That's where I work as the ILPQC executive director. But we have a lot of advisory groups. So our OB advisory work group meets every month. It's made up of nurses and physicians and patients and public health folks from across the state who meet monthly to talk about our initiatives. We have on the OB and NEO side. We have our OB and NEO community advisory boards that meet quarterly that are made up of patients and community stakeholders. And then we have our leadership committee made up of advisors and stakeholders from around the state who meet monthly. And then of course we have our hospital teams that are really the center of the collaborative, which really are all the birthing hospitals across the state who work together and meet monthly on webinars on the different initiatives they're working on. Perinatal quality collaboratives really bring together patients and families and communities, providers and healthcare workers, national organizations and state organizations to really try to move the work forward together. I think one of the things we do, I tell people all the time, we do a lot of cheerleading. Our goal is to get people in the right mindset that change can happen and that you can do this work together, because oftentimes people are so, they can get so stuck because we're all working incredibly hard. We've just come through the pandemic. There's been a lot of shortages of staff, both in outpatient settings and inpatient settings. And it's hard to think about taking on an initiative, working on quality improvement. But what we found is that this is a real key to reducing burnout, that folks feel really energized by working on quality improvement together, particularly when they're working across hospitals or across institutions. They can really learn from each other. So our goal is to engage hospitals to create an environment of improvement, motivate hospital teams to facilitate change. Again, that's that cheerleading we do. And then we really support hospital teams through collaborative learning. So we get lots of hospitals together to learn from each other. We give them data. Our hospital teams collect data every single month. It goes into our REDCap data system, and our hospitals can compare how they're doing across all the hospitals in the state. And then we do a lot of quality improvement support, a lot of one-on-one meetings, and other things we do to help. These are the initiatives we've done. I'm not going to be talking about all these today, but I will touch briefly on our mothers and newborns affected by opioids work, and then two of our current initiatives, birth equity and promoting vaginal birth. And so you can see we've been going for a little over 10 years as a collaborative. Some of the things that we've done, we've been able to affect reducing severe maternal morbidity related to hypertension by improving treatment for severe maternal hypertension within an hour. We really worked hard on our opioid use disorder, and I'll show you some of that work. We were able to increase screening and treatment for patients with OUD. And then on the neonatal side, we're able to improve breastfeeding rates and reduce the length of newborn farm treatment for opioid-exposed newborns. We just held our 10-year anniversary of ILPQC. Here are some pictures from some of our meetings of folks really working together, engaging patients, community, and in the end, it's really about making change happen. So I want to take a little bit of time to share briefly with, I'm just checking my time. Okay, I've got about half an hour. But I know I want to leave time for questions. So I'm going to share briefly now some of our initiatives, and you all can just see the work that we've been doing, how we've done it, and where we've been able to make change happen. Because in the end, we want to move from just having meetings where we talk about what we should do, and we want to put those that change in action. We want this action to happen on a large scale. We want to engage every hospital in our state, and we don't want to leave any hospital or any patient behind. Our goal is that everyone improves, and everyone proves to meet the goals of the initiative, so that we make sure that we're getting that quality of care standardized across all the birthing hospitals working with Illinois. So to start talking about our opioid use disorder, I sit on our maternal mortality review committee, and it's apparent to anyone, I think, who serves on maternal mortality review committees around the state, around the country, that opioid use disorder is a leading cause of maternal death. In Illinois, overdose is now the leading cause of pregnancy-related deaths. 34% of our pregnancy-related deaths, and it's even higher if you look at pregnancy-associated deaths, are related to overdose, and almost all of these are preventable. We need to move towards having optimal care for all pregnant and postpartum patients with opioid use disorder. This takes a lot of work and a lot of coordination. An article just came out this week that showed that only 1 in 5 Americans with opioid use disorder are receiving the standard of care and being treated with medications for OUD, even though this is one of the leading causes of death in the United States. So again, this wouldn't be acceptable if we were talking about patients with DK or diabetes. We'd be making sure that we get patients the care and treatment they need, and it is absolutely the same for opioid use disorder. One of the things we realized when doing this initiative that we had to do a lot of education of doctors and nurses, that in their heads, they were thinking of opioid use disorder as just a social work issue. They would see a patient with OUD and think someone should call social work to talk about DCFS and make sure the neonatology team knows this patient is at risk of NAS or NOWS. But they really weren't thinking about the patient in front of them as incredibly high risk of maternal death, as having a disorder, a chronic condition that's the leading cause of maternal death. And so we really set out to really change the hearts and minds of our doctors and nurses across the state and help them see opioid use disorder as an urgent obstetric issue, that it's a life-threatening chronic disease with life-saving treatment available, that there are key steps OB providers must take prenatally and on L&D to care for women with OUD, and that when you link moms to treatment, to medication-assisted treatment and recovery services, you can reduce overdose deaths for moms, improve pregnancy outcomes, and increase the number of moms and babies who can be together as a family. And so these were the key messages that we realized we had to start with, because if we didn't get these messages across, we could not do this work. If you have stigma and bias against patients with OUD, or just dismissal, or just thinking this isn't a medical issue, this isn't something I need to pay attention to, then you cannot provide optimal care for these patients, and patients will continue to die. So these messages became really critical, and we actually created a series of e-modules and a whole series of posters that we share with birthing hospitals across the state and emergency departments across the state to really get providers' attention. And those can all be found on our ILPQC website. We said that we need optimal care for all pregnant and postpartum patients with OUD. And we realized that doctors and nurses on labor and delivery units and emergency departments didn't know what that optimal care was. So again, we made posters. This is what the optimal care that we expect for every pregnant patient if we're going to save lives. To screen every pregnant patient for opioid use disorder with a validated screening tool, which means a self-reported screening tool. We assess readiness for medication-assisted treatment. Are they ready to start treatment? We counsel them on the benefits of starting treatment during pregnancy and in the postpartum period, and we link them to MAT and recovery treatment services with an active warm handoff. We provide Narcan or naloxone counseling and a prescription for every patient and screen for Hep C. We do warm handoffs, so we would link the patients effectively to treatment. This isn't about just giving someone a phone number. And then we provide patient education on OUD, NAS, and we reduce stigma and we promote empathy across our clinical team. These were the parameters that we said is optimal care, and we expect that every pregnant patient with opioid use disorder across the state should receive this optimal care. So we need to do a lot of education. We need to educate our patients about what they needed to be healthy during pregnancy and the postpartum period. We created these materials with multiple focus groups of women pregnant patients and postpartum patients who had OUD, and they picked out the pictures, they picked out the words, and really worked with us. So these materials are all available on the ILPQC website. Then we really leaned into education for OB providers and RNs. And again, we have the first one on Words Matter is about stigma and bias education, which is such an important part of all of this. We did a set of modules on how to provide optimal care. And then we had an education campaign with flyers and posters that we sent to birthing hospitals across the state, which are available on our website. And then we did simulation guides, which a lot of our resident and fellowship programs use to teach residents and fellows how to talk to patients with OUD and to do expert and counsel them about starting treatment. We also found that patient stories were the real magic bullet here, that when people listen to a patient talking about their experience with OUD, that's what broke through the stigma and the bias and helped people understand how they can make a difference and that they can save lives. So we developed this video in partnership with the PQC in Florida. This is Florida Angel Story, and it's just an incredible moving video, which I encourage you to share and utilize. It's available on YouTube. If you look at Angel Story ILPQC, I encourage all of you to watch it. So what did we do in terms of this initiative? We had 101 birthing hospitals in Illinois. 91 of the hospitals submitted data for this initiative. So they all were really very engaged and participating. We collected data on over 2,000 patients with opioid use disorder who delivered during the initiative, and we did a random sample of 21,000 patients. So every hospital collected 10 patients per month. So this is our data that shows how we're asking hospitals to put systems changes in place. So we always start with system changes, and red means you haven't started working on it. Yellow is our team's working on it, and green is we've got it in place. And I don't want you to look at each of these bars, but what you can see is that as we work through this initiative, our team's got these systems changes in place. They worked on the system changes really hard, and we were able to move everyone to green across these key strategies. So you have to really think about what are our system changes, how do we get them in place, and then how do we get culture change? How do we actually get those changes to mean we're improving optimal care for our patients? So this is the system changes our QI teams worked hard on. And then this is what I want to show you we did. On the right-hand side is labor and delivery screening with a validated self-reported screening tool. When we started the green, only 2% of patients on labor and delivery units were getting validated self-reported screening for opioid use disorder. By the end of the initiative, 88% of patients in the state of Illinois were getting screened with a validated self-reported screening tool on labor and delivery units. Prenatally, we've only got to 42%, so we have more work to go there, but we certainly increased the number of patients who are getting screened prenatally. So we made a huge difference of screening patients on labor and delivery units and identifying patients with OUD. This is increasing treatment with MAT and linking patients to recovery treatment services. The blue is getting patients started on MAT. The orange is getting them linked to appointments with recovery treatment services. And you can see we really significantly improved optimal care for these patients from 44% to 88% by the end of the initiative. This is getting patients a Narcan prescription. And again, this is the work that we're continuing to do in Illinois today because we only got halfway there. We made huge improvements. What this really opened my eyes is how much OB providers were not providing optimal care for pregnant patients with OUD. And this is a basic standard of care for all patients with opioid use disorder. These are all patients who had OUD on their problem list. And when we started, only 2% of patients had anywhere in their prenatal or labor and delivery chart that someone had counseled and provided them an Narcan prescription. So it's just totally unacceptable, an easy way to prevent the leading cause of maternal death, and no one was doing it. So we really doubled down in Illinois on working on getting Narcan prescriptions to patients, and this is an area we're continuing to work on now past the initiative. The other thing we always look at in all of our work is trying to reduce disparities. It was really important for us to stratify our data and look at where disparities are with our with getting patients linked to medication-assisted treatment. The orange is our non-Hispanic Black patients, the blue is white, and the black is overall. And what you could see is there was almost a 2 times disparity in who was getting linked to treatment. And our Black patients were half as likely to get linked to medication-assisted treatment for opioid use disorder as our white patients. This was completely unacceptable. And so really working on standardizing care and making sure that no patient is left behind, no hospital is left behind, everyone knows how to provide optimal care for every patient with OUD, we were able to erase this disparity by the end of the initiative. So I'm going to switch gears and very briefly show the promoting vaginal birth, mostly because I want to show you how we were able to reduce disparities here and some of the work we're doing very briefly. So we're working on reducing NTSB C-sections safely and promoting vaginal birth. This initiative has been going on for about 2 years, and we're working on increasing the number of C-sections that meet ACOG SMFM criteria. So if you have a failed induction C-section, did it meet criteria for failed induction, or did someone just decide, oh, she's probably not going to make it, I'm going to call this failed induction early, or I'm going to call a rest in the second stage, but was she really pushing for the amount of time ACOG recommends, or did we call it early because I figured she wouldn't get there? So we're really trying to say, if you're going to have an NDSV C-section, did it meet those recommendations? So looking at that data, and then really making sure that our providers are really educated about what those standards are. Our goal is to reduce NTSB C-sections safely, so the goal of less than 23.6, to increase the percentage of C-sections that meet those ACOG SMFM criteria for their definitions of indications, and then we want to address disparities in NTSB C-sections. These are the strategies our teams have worked on for the last 2 years, using delivery decision huddles and checklists to really make sure everyone across the team is thinking about those indications for C-section, whether a patient meets those indications, clinical team education and buy-in. Sharing unblinded provider level C-section rates was probably the most important and effective thing that our teams have done. When you share those unblinded provider level data at your hospital, you really start to have those conversations about where those differences in C-section rates are and how we can all do better. Fallout reviews was another really important area. When a patient did not meet indications for their C-sections, they did fallout reviews where they tried to understand what was the reason. Is it just a documentation issue, or did it really get called too early and that we needed more patients with pushing or more patients with the induction? Labor and delivery support, lots of our nurses did spinning babies and all sorts of stuff to support our patients, and then really working on shared decision making. This is what we've done so far. So our C-section rate was 24.9 when we started the initiative. We started to improve, and then Omicron and Delta hit. And the C-section rate went back up again, and we had a little bit of trouble during that time of nursing shortages. And one of the things we found is that our disparities got worse during that time. So as there were nursing shortages around the time of the pandemic, the disparities in NTSB C-section rates actually got worse. But now over the last year, we've been doing better. Our overall C-section rate for the state, for the collaborative, is meeting the goal. And we have 60% of hospitals across the state achieving the goal, when we started at only 35% of hospitals across the state were at goal. The other thing I think we're really proud of is addressing the disparity gap. So here you can see the dark blue is white patients, the light blue Hispanic, and the pink Black patients. And there was a clear disparity across, there was a clear racial disparity, racial and ethnic disparity when we started this work. You can see the disparity get worse during the pandemic, and now you've seen a closing of that gap. It's not, disparity is not gone, but it's significantly reduced. And has been for the last 2 6-month blocks, which is exciting. And this is an area we're going to really continue to focus on in sustainability. Okay, with the time I have left before we move for questions, I don't want to leave time for questions. I want to share the work that we've done that I think is just really foundational to all the work we've done and all the work we'll be doing in the future. And so our teams decided when they voted to do the promoting vaginal birth work, and our teams come together every fall and vote on future initiatives. The team said we're going to do promoting vaginal birth, but we want to do a birth equity initiative at the same time that really focuses on key strategies where we can make a difference on addressing disparities in maternal health outcomes in our state. And the teams voted to do this as an additional initiative. Usually we only run one initiative at a time, and this was definitely our teams really said we can't wait until promoting vaginal birth is done. We have to start birth equity now. We have to be working on these key strategies. And this is what we did. We set to work talking to lots of community stakeholders and a lot of patient focus groups. We did focus groups with patients of color. We talked about key strategies. We really talked about what mattered to our patients. And these are the key strategies that we ended on. Optimizing race and ethnicity data collection and reviewing key maternal quality data by race, ethnicity, and Medicaid status. Doing universal social determinants of health screening, and then having a system to link patients to appropriate resources in the community, ensure those patients are getting appropriate linkages, and so they get the services they need, and that someone in the clinical team is really thinking about those social determinants of health issues and following up with patients. sharing respectful care practices on labor and delivery, and then surveying patients before discharge on their care experience using a PREM for feedback, engaging patients and community members for input on quality improvement efforts, so really teaching our hospitals and really helping our hospitals to figure out how to engage patients and community members while they're doing their QI work, standardizing postpartum safety education and schedule an early postpartum follow-up for all patients, and then implicit bias and respectful care training for providers and staff. So these were our 6 key strategies our hospitals started working on when we began this work in 2021. Over this last year, we've tried to focus on 3 key areas. Our teams really wanted to really focus on what we've called bringing birth equity to the bedside. And so in the last, I would say this last year, since our last annual conference last November, these 3 areas have been the big push for our teams. Clinical teams working on actionable respectful care practices. So really not just putting a respectful care poster up in a birthing room, but really saying, how do our teams really implement each of these respectful care practices in a real way? So really thinking about respectful care and acting on it, and then increasing the % of patients who complete a PREM survey, and then taking that PREM survey results and feeding it back to the clinical team members. Achieving patient and community engagement strategies for input on QI efforts. So what are those achievable things that our teams can actually do? And then really working on that SDOH screening and a process flow to link patients with positive screens to community resources and services. So this is where our teams really felt they needed to focus after 2 years of working on this work together. So in terms of implementing universal SDOH screening and linkage to appropriate resources, we have a lot of tools in our toolkit that you guys can look at. We developed and shared sample screening tools to screen for SDOH. Many of our hospitals now have SDOH screening tools embedded in their EMRs, and they've been doing a lot of work sharing with community health clinics, FQHCs, and other prenatal settings to try to make sure that they're screening effectively for SDOH as early in pregnancy as possible. Doing community resource and mapping tools, and our teams right now are really working on linking to community resources that make a difference. Who are those real important, like community health workers and home visiting associations? A lot of the folks who are on this call today, how do we make sure that we're building those bridges between labor and delivery units and prenatal care settings and those folks in the community who really know how to get the resources to the patients? We've created folders, we did handouts, we really helped our team sign up for findhelp.org, which is a way to refer patients directly to resources in their community. And then we developed a process flow for making sure that it wasn't just about screening and checking a box, but it was really about the linkage to patients in the community and really figuring out those community resources. Our teams developed respectful care posters. This was something that we worked on with a series of focus groups of patients of color who helped develop these respectful care practices, and then helped develop these posters that went out in both English and Spanish to all the birthing hospitals in the state. Treating you with dignity and respect throughout your hospital stay, introducing ourselves and our role, learning your goals for delivery and postpartum, working to understand you, your background, your home life, communicating effectively across the team, partnering with you for all decisions, practicing active listening, valuing personal boundaries, respecting your dignity and modesty, recognizing your prior experiences with healthcare may affect how you feel during your birth, making sure you are discharged after delivery with an understanding of postpartum warning signs, ensuring you are discharged with the skills, support, and resources you need to care for yourself and your baby, protecting your privacy, and then being ready to hear any concerns. So these practices went up across the state. And the goal was to post the practices, have our teams work on them, and then ask patients before they went home using our PREM survey if they received these respectful care practices, and then share that data back with the hospital teams. Here's some of pictures of hospital teams across the state who are working on actively engaging in respectful care, printing out the different respectful care practices and everyone saying what they're going to work on for that day, signing a big poster with all the respectful care practices to commit to these respectful care practices, and really just actively talking about the concept of respectful care, what it means, and how do we actively do it. We did a lot of educating providers, nurses, and staff. This is not a one and done. You can't do just an e-module on implicit bias and think that you have an understanding of how this works and how to do better. It's an ongoing process of constantly thinking about how to do better. We did Speak Up anti-racism training. We provided the diversity sciencey modules. And then we did a lot of screening of some of the amazing videos that are out there now. There's a lot of great documentaries, videos, and movies that you can do a screening for your doctors and nurses and have discussions that I think are really meaningful. We focus a lot on engaging patients and community partners for input. All the work that we're doing, you're going to be able to do it better if you're listening to patients. So if you're working on activating respectful care practices on your unit and you're thinking about how do we do a better job of active listening? How do we do a better job of shared decision making? Do you know who knows how you do a better job? It's your patients. And so figuring out how to get patient partners on your QI team or patient partners who you can meet with to talk about respectful care, that is what really makes a difference. And it also really helps doctors and nurses take a minute and really start thinking, I need to take this seriously. Maybe I don't provide the respectful care I thought. Maybe I try every day to do respectful care, but maybe there are things I could do better. And so that's where engaging patients really helps us do that. So we've done a whole series of things that I'm not going to go into, but we've done regional community engagement meetings. I'll share briefly some quotes from that. We are now working on helping all of our hospitals hold a respectful care breakfast, where they're inviting patients to come in and talk about their experiences with respectful care and have a breakfast with doctors and nurses on their unit where everyone wears a name tag, everyone has some donuts and coffee, and then there's a discussion of respectful care. And we're asking all of our teams to identify a patient partner to serve on their QI team. And many of them are identifying patient partners from those respectful care breakfasts. So really briefly, because I want to have time for questions, let me just wrap this up. This is some of the work we've done on the birth equity. Again, the green shows teams putting these systems changes into practice. You can see the work moving systems changes into practice. Here is provider and staff birth equity education on respectful care and implicit bias across providers, nurses, and staff. So just a huge push on moving this education forward. Here's screening for social determinants of health on labor and delivery units across Illinois. Again, hospitals really embraced the S2H screening, and 62%, we're now at 75%. I haven't updated this slide. 75% of patients now with a positive screen are getting connected to resources and services. Where we started out, we were under 50%. So far in our PREM survey, we actually now updated, have over 3,500 PREM surveys across, I think, 63 hospitals. We have a really diverse sample of patients who are reporting the PREM surveys back to us. This is one of the flyers we've used to ask patients to tell us about their birth experience and complete the PREM survey. We have multiple languages they can do the PREM survey in. And the PREM survey, the thing we're really getting back about the PREM survey is really focused on improving shared decision making. I would say that's the number one comment that we get back from teams, is that we need to continue to improve shared decision making with and partner with our patients. To wrap up, I'm just going to share some of the data we got back from 10 regional community engagement meetings that we held between our birth equity teams. And then we did a series of where we brought patients and community stakeholders in to talk to our teams about their birth equity work. And we did this during last year in 2022, and 66 hospitals participated. I just wanted to share, to wrap up, the themes that were discussed and what our patients, community stakeholders, and our birth equity teams felt. So this is what they felt coming out of those 10 meetings across the state: that respectful care matters and involves connection with people as individuals without judgment, and includes listening, discussing, and providing explanations. One of our doulas summed it up really well. She said, "Sit and listen. A few minutes can change a lot." That patient feedback is critical and necessary to improve care. That hospitals must work with community stakeholders to identify existing community resources to address unmet needs. Here's an OB who said, "Our community has so much to offer. I now have a better understanding of how to help our patients access it." Care coordination is necessary and currently insufficient for pregnant and postpartum families. I know many of you out there do care coordination, work as community health workers and patient navigators. Your care is so important, and the theme that came across was we need more. We need more care coordination and better care coordination for our pregnant postpartum patients in order to address the maternal health crisis. Pregnant patients must be better informed of community resources and get help connecting with what they need. That was one of our patients. Creating meaningful change toward birth equity requires input from both patients and community. Here's a nurse, labor and delivery nurse, who said, "We must reach out to people within our community who have perinatal care experience and create space for feedback." So to summarize, it will take ongoing intentional change to address maternal disparities, but together we can make change happen. Maternal mortality and unacceptable disparities need our urgent action and attention. Listening to patients and communities are going to tell us what changes are needed. Building collaboratives where you can find them will help make change happen faster, and consider how you can take action where you are. This is our website and our email with any questions, and happy to share all the resources I shared today. Please let me know what questions you have.
Thank you so much, Dr. Borders. That was a wonderful presentation. We do have a few questions that have come in through the chat. The first one is from Shelley Lanigan. She is asking, will the validated screening tools be shared?
Is this for the opioid use disorder?
Yes, I believe so.
So we do have those screening tools. If you go to, if you Google ILPQC and click in MNO, or Mothers and Newborns Affected by Opioids Initiative, and you go down to screening tools, you'll see a link to the key screening tools that we used across Illinois. I would say the most common screening tool are the 5 Ps and the NIDA quick screen. And then our hospitals really like the integrated health screening tool because it has the 5 Ps embedded in it, but it also asks about emotional well-being. It asks about smoking. There's like some other, there's some different components. And at the bottom, if someone says yes, it goes down and it tells exactly nurses and doctors what you should do. So it screens for intimate partner violence. So I think that was probably the most common tool used across the state, was that integrated health screener that has the 5 Ps in it, and then the 5 Ps and the NIDA quick screen. I would say for sure those were the ones that were used most commonly across Illinois.
Thank you. Thank you for that detail. This next question is from Isabel Fangman. Her question reads, there have been cases of women who used drugs during pregnancy and experienced miscarriage. Some women end up being prosecuted and even imprisoned for the death of their fetus because providers reported it. This is problematic because women may be hesitant to seek care for fear of prosecution, especially in the current climate of Roe versus Wade. Is anything being done to prevent this situation in Illinois? And if so, what? Thank you. Learning a lot from your presentation.
Thank you for your important question. If I would have had more time and I was only speaking about the OUD work, I would have spent some time talking about that issue. It is crucial that we talk to legislators about this issue in every state. There is a huge push across the country to decriminalize opioid use disorder and pregnancy. We have to decriminalize. There are to have patients be imprisoned for this horrific chronic medical condition of addiction is horrific. And it is currently the leading cause of maternal death in our country. Opioid use disorder, leading cause of maternal death. By far and away, it's the leading cause of death in Illinois. And to have patients criminalized for being identified for this leading cause of maternal death, it only continues to increase maternal death. And so what we need is a system that really identifies patients with empathy and compassion and realizes that anyone can have an addiction. Anyone can find themselves with this horrible chronic condition, and we have to get patients into treatment. And when we have a system set up that criminalizes patients, they're not going to come forward for treatment, and we will have more deaths. And so I really urge you to look for others who are working on decriminalization. There are groups working on this across the country. Certainly this is an area I testified this year in front of our state legislature. There's a lot of things we are doing well, I feel like, in Illinois, but we still need to make sure that patients are not getting reported to DCFS in ways that create fear. And when you create fear, you cannot provide good care, and you're not going to reduce maternal deaths.
Thank you. This next question. Yes, go ahead.
I said, so please testify if you can, if this is an issue that you can bring. It's a clear area of maternal health justice.
Thank you. I apologize for jumping in a little
No.
early there. This next question is from Tomi St. Mars. Her question reads, have you looked at the number of prescriptions filled once the prescription is provided for naloxone?
Yes, so the challenge with naloxone is that if you provide a prescription, the chance of it getting into the patient's hands is still not high. There are many barriers to getting it. So actually, thank you for asking that. And again, if I had more time, I would have spent a lot of time on Narcan. So what we've moved to in the state of Illinois, when we started doing this work, no one was even talking to patients about it. So then we moved to counseling and providing a prescription. Or they said, oh, the patient could just go to the pharmacy and ask for it. If any of you have ever walked into a pharmacy and asked for Narcan, there is so much stigma and bias related to that question. If I walk in and ask my pharmacist for Narcan, it is, for many reasons, people are going to have a lot of barriers to doing that. And even if I write a prescription, a patient may not believe that they need it, right? They're thinking, I'm not going to overdose. So they may not go get that prescription filled. So what we've moved to in Illinois is this program called DOPP. And so we have a program where we can sign up as a hospital or as a prenatal care site and apply for the DOPP program and have free Narcan kits, boxes of free Narcan kits sent to our labor and delivery unit or emergency department or outpatient prenatal care site so that we can hand out free Narcan kits to our patients. So that's our next big push. The other thing we worked with hospitals was to set up a med-to-bed program where the goal was to get a patient a Narcan kit in their hand before they left the hospital after after their delivery, so that their pharmacy would stock them and they could get a med-to-bed where they bring it to the patient before they go home. And we counsel patients, and often a patient will say to me, well, I'm not going to overdose. I haven't been using, I've been clean for 6 months, I've been clean for a year. Postpartum period is the highest time of relapse that we have, and that's why the postpartum period is so deadly for patients. They've often reduced usage. It's an incredibly stressful time. Some of our patients have had babies removed from their care. They're often suddenly go from having lots of prenatal care and lots of support to having much less. Some of them lose their Medicaid status. So it's just a very high risk time. And I tell patients, having a Narcan prescription is like having a smoke alarm in your home. You don't put a smoke alarm in your home because you think you're going to burn your house down. You put a smoke alarm in your house for safety. And I use that over and over again with patients, like having a Narcan prescription in your car, in your purse, at your home. That's like having a smoke alarm in your house. It's for safety. And I also make sure to let them know that they could use this to save someone else's life, a friend or a family member, or someone they encounter at the grocery store in the parking lot. So really important that we get more Narcan out there. And I encourage you to find ways to get Narcan kits into patients' hands, not just giving them prescriptions.
Thank you so much, Dr. Borders. I think we would definitely could just have you speak to us for an entire day, and we would just continue to learn so much from you. Thank you so much.
I'll do that, and make sure, folks, if you want to, you can reach me at that email. If you have additional questions we don't get to today, or you can find all of our tools on the ILPQC toolkit. And if you can't remember the toolkit website, just Google ILPQC and it should pop up. Thank you, everyone.